The PharmCast is a podcast sponsored by the Maryland Pharmacists Association. I'm your host, Aaliyah Horton. I'm the Executive Director of MPHA. And in my role, I have the opportunity to meet so many fascinating people within Maryland and around the country that are engaged in the practice of pharmacy. They're stakeholders, they're innovators, collaborators, and advocates. And this is my opportunity to bring those conversations and experiences to you. And it's another way that MPHA is fulfilling its mission to strengthen the profession of pharmacy, advocate for pharmacists, and to promote excellence in pharmacy practice. My hope is that at the end of these conversations, you will leave informed, engaged, and connected to pharmacy and our Maryland pharmacy community. Hi, and welcome to the PharmCast. Today, I am talking with Dr. Barry R. Meisenberg. Dr. Meisenberg is the chair of the Department of Medicine at Anne Arundel Medical Center. He joined the hospital as medical director of the AAMC Gayton and Joanne de Caceres Cancer Institute in 2008. He serves as the physician leader for quality improvement and patient safety initiatives, and as director for the Center for Healthcare Improvement. He oversees the AAMC Research Institute. In these roles, he, in conjunction with nursing and administrative leadership, as well as other chairs, oversees and develops a long-range strategy for healthcare quality and performance improvement. And so I think you are our first physician guest in about 13 or 14 episodes, so welcome.
Well, hopefully I won't ruin it for anyone who follows behind me, any physicians who want to come on after me.
All good, I am sure. And so the reason why I wanted to talk to you is on a couple of folds. So one, MPHA received a grant from the Cardinal Health Foundation. We're one of 5 states to focus on optimal prescribing for pain management and to look at opportunities for pharmacists, patients, and physicians to collaborate and kind of change the way we work to ensure that we're collectively working to reduce opioid misuse and abuse and hopefully deaths. And as part of our project, we actually decided to focus on Anne Arundel County as one of the key areas. And so in doing our research, we came across an article that really talked about what AAMC did, which was just phenomenal in reducing opioid prescriptions by 65%. And so I want you to talk about that. And I know that's not something that you just kind of click your fingers and say, okay, we've done it and we've made that change. Can you kind of walk through that process of how you started and what you had to go through to get there?
Sure. Well, thank you for highlighting this work and for considering this is important. So I think the first recognition is for a health system or a physician practice to understand that we are part of the problem. And I think it's well-known story now how over 30 years, the amount of opioids per person in this country has grown well beyond what's prescribed in other countries, even countries with similar demographics to our own. Mm-hmm. And how that occurred is, I think, a common story now with marketing, which included physician leaders, by the way. And a health system should say, some of this physician education took place in our spaces. Was sponsored by health systems. And these opioids are being prescribed by our doctors, either employed or on the medical staff. So we sort of own this problem, and we sort of have a responsibility to the community, to ourselves, to correct it. And we'll go into the details of what I'm talking about in terms of our responsibility, our role, and a few understandings. So if you as a health system understand that, then you take ownership of it. And when you think about the part of this work that includes connecting to the public, health systems are in a very good position to do that. We already have, tools to communicate with the public about everything from wearing sunscreen to getting your blood pressure checked. And, ideally, health systems are trusted purveyors of information. And when we say to the public, look, we have a problem with opioid overprescribing is what I'll call it, that contributes to the larger public health problem of opioid overdose, I think that voice will be listened to.
Now, let me ask you this question. So when you guys came to that realization, was that well, I know Baltimore and around the area had a huge, or has, a kind of a huge opioid addiction issue. But did this sort of realization come from just what was going on in the community, or was it like with the CDC prescribing guidelines? Was there something that sort of pushed you all to reconsider?
Well, our initiative began before the CDC revised the guidelines. And it came about because of the media attention to the issue of opioid overdose.
Okay.
Deaths, overdose in general, and deaths. And you remember the police station in Anne Arundel County, they had a list they maintained daily or weekly in front of their buildings as a way of getting attention. So it got our attention, got my attention. And what we did was we looked just to see like what's going on in our practitioners. We had this electronic health record, so we could see all the prescribing activities that was occurring among our physicians. And what we found, the first finding was tremendous variability among physicians with similar roles in the organization. So if you've got a group of emergency room doctors who see a similar amount of patients in a similar kind of patient, they should have similar prescribing. But it turns out they did not. And subsequently, this has now been widely reported every place elsewhere. Primary care doctors. Now, there's a lot of variability in what kind of patients certain primary care doctors see.
Right.
But tenfold difference in amount of opioids prescribed, or either in amount or the number of patients.
Mm-hmm.
How many of your patients or how many of your new patients are getting an opioid prescription? So those are things that you can measure. And even something as similar as a discharge prescription from a surgical procedure, we saw a variability. So a knee replacement, a shoulder surgery, a lung operation, patients were going home with different amounts because different prescribers were sending them home and there wasn't any standard. What's more is we found that on patients who were discharged from the hospital, the amount they went home on had no correlation with what they used in the hospital. So if 3-day recovery, 5-day recovery, it was, I guess the only word for it, the only fair word is idiosyncratic.
Okay.
So right away, without much digging, we knew we had an issue. And so our initiative began with an education campaign of prescribers, but we also included the public, who by this time was very, very concerned about this. Mm-hmm. Many members of the public knew someone or heard of someone or had a friend whose kid was opioid overdose at some level. And so the public sort of met us halfway on this issue, fortunately. So the physician education is extremely important because it's hard to compete with pharmaceutical detailing, but basically what you're doing is reverse detailing. And what we tried to do is link some basic facts about the opioid problem to prescribing. And this is, from the medical literature, that there is evidence that the more opioids a naive patient is exposed to, I mean opioid naive, someone not already on them, the more likely, with the first episode, the more likely they are to become long-term users. So dose matters. And that, so that's one important fact. Another one is that the more frequent use and resupply of opioids early in the course can lead to more long-term users. the fact that people who are known opioid abusers by, a medical definition of opioid substance use disorder or opioid addiction, they will frequently tell you that they got their initial opioids from non-medical sources. So the idea of doctor shopping is actually much less common than getting opioids from a friend, or stealing them from a source in the household. So that information makes physicians a little more aware that their prescribing does play a role. So when you send someone home with 90 Percocet after a shoulder surgery, and the patient uses 10, those other 80 are available for what we call diversion, what the law enforcement folks call diversion. Right. And whether that's willful or through essentially theft, it does happen. And that's how some people get their initial start. And when you look at that data, it's pretty shocking. We even had hospice patients whose opioid, when the hospice patient passed, the opioid that we supplied to the patient was not accounted for and not recollected. So this is a pretty interesting and worrisome phenomenon that grabs the attention of physicians. And then the next piece that you move into is some data that already existed. We actually created our own, but some data which are I should say, added or counted our own experience that patients use much less than they're prescribed. And this is true whether it's breast surgery, orthopedic surgery, abdominal surgery. You can find study one after another of different types of surgery. Now we're focusing on surgery, but it's also true of other injuries. So we'll prescribe for the 90th percentile. And in fact, patients will use 10 pills, and we've given them 60. Okay. What happens to the other 50? They're sitting on someone's medicine chest, subject to diversion or theft. So when you see that data, we really got physicians' attention, and they were very, I must say, willing to participate in this initiative.
Oh, that's great that you also, because we've talked a lot about in these conversations that we've been having about kind of stigma from the patient side, but also in the conversation with physicians or with pharmacists about not sort of putting a negative spin on people's practices, because that's what they know, but really taking data is really a sort of a neutral way to start that conversation and to make change.
Right. So that's a critical part of this as a health system. And most health systems or large practices should be sophisticated enough now to be able to collect data. So data is empowering, and what we were able to show individual physicians was their practice pattern compared to their colleagues. And you can cut the data in numerous ways. You can show total amount of morphine equivalents, average amount, the percentage of patients who got an opioid prescription from you. There's all different ways of measuring that. You might want to say, well, I know you've got these two basically pain management patients. Well, they're outliers. We'll take them out. Now look at the rest of your practice. So showing people that data was extremely powerful. And they all told us that. And then the other feature of this is to have responsible medical leadership on a departmental or division level. So this became a priority for numerous medical leaders in our health system. And I can think of a few surgical leaders in particular who took this on as a major quality improvement initiative for their group. And in some cases, the most important quality improvement initiative. So they were able to, either from the literature or from our own growing experience, develop their own best practice. Okay. And they created this guideline with consensus and with data follow-up. And we can talk about that shortly, about how we made sure we were not under-prescribing. They made sure that the guidelines were followed, and it became a group effort. So now the default is to use the standard prescription. Now, prescribing amounts. And so the electronic record can be a very useful tool if the first prescription you go to is the so-called correct one. the lower amount or the appropriate amount, and not let people either free text in how many Percocet or default to a higher number, which actually existed in our computer set. When you type in an opioid, you sometimes got a pre-filled prescription for 90 or whatever. It was easy to just sign it and move on. So now let's make the lower amounts, the standard amounts, the easier thing. Oh. And then, as I say, the medical directors were all over that data, sharing it frequently, the way you would with any quality improvement project. And so this happened in our emergency department, in our primary care practices, in our numerous of our surgical divisions. And that's why the numbers dropped, because we were over-prescribing. Now, when you do this, you want to make very, very sure that you're not under-prescribing or you're hurting the patient in some way, because that is not the goal.
And that's something, I'm glad you touched on one thing, because I was going to ask you, like, who are the stakeholders? It sounds like the way you express is that you had champions within the leadership that really held everyone accountable. But as you're about to transition to with patients, I know we've gotten feedback when we've tried to do some de-prescribing and make changes. The pushback from some patient advocacy groups, just saying, I need this pain treatment. So can you go in? I think you're about to go into that a little bit. How does that?
And I think there's multiple different groups of patients. There's people with chronic pain. There's people with advanced cancer to consider, and then there's the majority of public who are opioid naive. And what we're trying to do, really, when we focus on those individuals, the largest group, is avoid over-prescribing. And so, well, how do you know you're not over-adjusting, that you haven't overreacted? Well, you can check to see if your patients are getting opioid prescriptions elsewhere, and we have access to that. You can see if they ended up calling back in for extra prescriptions. So you didn't send them home with enough and they're calling you 5 days later. And or you can check on emergency room visits. Now, we've done all those things and did not see an increase in any of those parameters, nor did we see a worsening in our patient satisfaction levels regarding pain management.
Okay.
And anecdotally, the patients who we have these good discussions with are actually appreciative, because the public, as I said, was extremely aware of this problem. Now, that's not the kind of patients with pain who are worried, and there were examples that some high-profile anecdotes and patient stories about people being cut off because doctors were worried that they were being scrutinized, that law enforcement was looking at them, that they were worried that the health system, was scrutinizing. So we actually, when we had the opportunity to, participate in national guidelines, we wanted to make sure that any guidelines created was not overly detailed and prevent, individual medical judgment being used for an individual patient. And I think you can do both. I think you absolutely can do both. But the public, I will tell you, is an absolute partner in this. And at the same time we were educating physicians, we were educating patients, and we had excellent peripheral material from the County Department of Health on opioids, others available from Consumer Reports in terms of avoiding or opioid alternatives. And we were also telling patients who do get opioids to store them safely,
right.
A message that we continue to repeat.
And so did you all engage with the pharmacy community at all? Or how do you see, if you didn't or haven't, what opportunities do you see for engaging the pharmacy community in continuing to manage this issue in the best way possible?
Well, we did within the health system. Pharmacy as a department was very involved in creating the tools for us to measure. They helped us write, standardized order sets, all of which had to be improved by the P&T committee at the hospital, Pharmacy and Therapeutics Committee at the hospital. So they were involved. At our institution, I know they're not prescribing, and they are more consulting basis in terms of inpatient care. But the broad world of pharmacist activities might include helping to do pain management, certainly side effect counseling,
Yeah.
and safe storage. I absolutely think is in the pharmacist's wheelhouse, so to speak. As is this issue of concurrent medication risk.
Mm.
So there are other sedating medications that patients may take concurrently, some of which you know about, some of which they don't tell you about.
Yes, we've been working on some. We just actually MPHA just partnered with a company that's going to be helping pharmacists look at some of that data and additional risk factors and a whole host of information as to how the medications are interacting and helping patients figure out, well, maybe they need to just move the time of when they take a particular medication from when they're taking another because of the metabolism, everything. It's really kind of fascinating stuff. One thing I did want to ask you about is your thoughts on some of the feedback that I've gotten from the pharmacists that are outside of the hospital system, but they are receiving prescriptions. And there's been a kind of a national conversation about this, about putting diagnostic codes on the prescriptions so that when you have a situation where, pharmacists may be concerned about the prescription that the patient got, if they see the diagnostic code, then they can say, okay, this makes sense, or, they can make some judgment, and then they don't necessarily have to make those phone calls to the physician with questions.
Yeah, there are various ways of improving communication. Certainly, that's one. I've come to write, if I'm writing PRN opioids, I write for cancer pain. I'm an oncology doctor in my own practice, and it conveys a little bit of information if there is in fact oversight either at the pharmacist level or the insurer's level. I add that to my diagnostic codes, my ICD-10 codes. Now I'm very careful to do that when someone's getting opioids from me. So I write cancer pain or joint pain or something. I make it clear, so it's not just part of an oncology visit. So I think that will all, be just another way of exchanging information, for sure. Will it really change anything? I don't know. It's easy enough to add those codes. But again, it's not
our pharmacists find it to be very helpful. So thank you.
That's good.
It's very helpful for them.
Yeah, I'm sure it helps them relieve some comfort, adds to their comfort level about prescribing.
It does. Yeah. It does.
Yeah. So I think it is a collaboration with all these folks. So with all these initiatives, and many were built into the EMR, we were able to we're over 70% from our baseline. Of course,
it's amazing.
Despite a higher volume of activity.
It really is amazing. Like I remember when I read the article, I was just kind of taken aback because so many entities are trying to figure this out. But I thank you for kind of walking us through that, because it's really helpful, and I think it'll be impactful for other groups that are looking to do the same work. And you said there was a JAMA article
on this. We presented at the Maryland Patient Safety annual meeting. We did some sharing of the information, and we wrote a paper about it, which is almost like a step-by-step guide, or at least in categories. It was published in a journal called JAMA Network Open Access.
Yeah, we're definitely going to link to that and share that information.
So the categories of activities, the bundles of interventions are in that paper.
Awesome.
And I think most health systems should be able to do this, and takes leadership. And I should mention that our hospital leadership raised this to a very high priority level.
Mhm.
And they made this a major focus of, part of our community work. Or we're constantly working to improve the health of the community.
Right.
And whether it's encouraging, weight loss or screening, this became another very high priority. And I think that's enormously valuable when that happens.
And actually, that is a great segue, because the last part, I didn't give you a heads up on this part, this next question. As most of the conversation that I'm having through this podcast are with healthcare professionals. And so it's always fascinating to me as what are healthcare professionals doing for their own wellness and taking care of themselves. You all are so engaged with the community. You go into these roles to help people and to improve patient outcomes, but you also have to look out for yourself. So I'm putting you in the hot seat. So what do you do to kind of bring yourself back to center, or take a break and kind of make sure that you're okay?
Well, thank you for asking. There is a lot of interest in healthcare provider wellness, no matter what part of the health system you work in recently. That question pre-COVID would have been a different answer than during COVID.
Yeah,
not yet post-COVID. So I can tell you that for the last 13 or 14 months, it's been all COVID all the time practically. It's almost you can't be really almost unprecedented, so that's not a real word, a real term, but it's extraordinary in my career, the amount of effort and the size of the emergency, the amount of suffering. So I've probably neglected my wellness to some degree, but I get great satisfaction from knowing that both myself personally and our health system is doing what needs to be done to meet this emergency. And whether that's providing antibodies or research trials or just the effective management and organization of care, it's what has to be done. I get satisfaction from that. I don't need to go to Disneyland or on a cruise because I think I'm doing important work. I'd like to do some of those things.
Yeah.
It's safe again.
Yes. And I'm actually glad you brought that up. I was so focused on this project and the theme of this conversation, but yeah, we're surrounded by this huge pandemic. And how has that, you've already got these strategies in place, but have you seen something different? And I've been reading a lot about kind of the post-COVID issues with people that are having all kinds of different medical concerns once they sort of recovered from COVID. Are you seeing that, and how is that being addressed?
Yeah. So the patients themselves are calling them long haulers. The NIH has a different term, post-acute sequelae of COVID or something like that. So we have established what I call a COVID recovery service. We need better information about the number of people with these sequelae, the severity, and who's at risk, let alone interventions. So we got a lot of learning to do, but we do have this service set up now at Anne Arundel Medical Center. They are, I know similar programs at Johns Hopkins and many other places are going to have to do this. What I'm reading is an enormous wave of ongoing medical problems that I'm really worried about, because some of these things are not going to be easy to treat, and I just hope they're short-lived. But on the COVID response, I do, since I'm talking to the Maryland Pharmacists Association, want to just mention one very important project that the pharmacists have been very intimately involved with, and extremely important quality improvement, and that is the standardization of care in the hospital. So when this tidal wave rolled over us in March and April of 2020, it presented novel syndromes and no guidelines in which to treat. And, I don't want to scare the public and say the response was chaotic, but it was very different than our usual measured, data-driven, even skeptical approach to interventions. Well, all of a sudden, we were flooded with patients with very sick, and there was this don't just stand there, do something approach to medical care. Mm-hmm. And it was, as I say, a little idiosyncratic, which meaning individual physicians having learned from an alternative source were making individual, interventions and decisions. So we organized a management group between the two hospitals of Luminous Health, Anne Arundel Medical Center, Doctors Community Medical Center in Lanham, and with pharmacists from both institutions. And we just started at the top and said, let's work through this. What do we know about these interventions? What works, what doesn't work? What should we be doing? What's the level of evidence? And we started, with steroids and anticoagulation, hydroxychloroquine. What do we know about that drug? On and on. And so we even included our learners, our pharmacy students, our pharmacy residents, pharmacy students, and medicine residents to help present the data. And they at least got to see the evidence-based process in action. Because if you just went to the floors, you might see, oh, this is how we practice. I got an email from a buddy at another hospital in New York, and this is what they do there, so I'll do it too. That's not how we want to practice. And I think it's fair to say we started off a little bit with that in this pandemic, and we eventually gained control of it. And I'm very grateful to our pharmacists and our health system for helping, set up that program.
That is fantastic to hear.
So we're working on publishing that outcome as well. Okay. And I think it was a very, very, I'm sorry it took a few months, but I'm glad that we have it now because there's new data all the time. It's almost too much to keep up with. And then there's all these alternative sources. Think about it. We didn't used to have email chains, blogs, press conferences, and then this whole issue of medical preprints, which are posted in a format but not peer reviewed.
Okay.
And this is, a challenge for all of us that started with COVID and probably won't go away. It's probably be true of every other entity.
Yeah. Well, it's and thank you for recognizing the pharmacists. And when you get this data ready to present, you can come to us. We'd be happy to give you a forum to share.
Maybe I'll give you one. I'll come on with one of our pharmacists.
That would be awesome. Did the work.
Yeah, I will share with you a little essay I wrote about this phenomenon. I'll send it to you by email.
Okay.
You can attach it if you want from the American Journal of Medicine. Just saying, we need to be skeptic again about how we make an intervention. And the point I made was that the route from in vitro laboratory hints to the patient's MAR was shortened and straightened. And there was stuff that you were reading about in a paper that went right into patients because someplace said it might be helpful. And if you will think about it, at the beginning there were also people saying take patients off ACE inhibitors because we know this virus, the spike protein, binds to the ACE receptor. Take them off the ACE receptors, antagonists. And don't give people chemotherapy. And there was all kinds of noise. I'm calling it noise, substituting as real medical information. And we had to sort through that. And we absolutely needed the pharmacist to help us do that.
Thank you very much.
Yeah,
and I really appreciate you taking the time to sit with me. And I know it's still a busy time, and hopefully we're starting to taper down a little bit with the vaccinations increasing. But thank you for all the work that you all have done. I know it's been a tough, like you said, 12, 14 months. But hopefully there is a light at the end of the tunnel, and we'll see you through
Yeah,
at the other
I'd
end.
like to. I certainly hope so. We all do. We all could. We all need a break, that's for sure.
Yes. Okay. Thank you. Thanks for watching, and please be sure to like, subscribe, and rate the podcast on all major podcast platforms. We look forward to dropping more great conversations, and of course, sponsorship opportunities are available. Just contact us at MPHA. Thanks.